Hello, thank you all for attending the second of the WHS 2025 Fall Webinar Series. Today's webinar title is Burns and Advanced Diagnostics Part 2. Please note if you have any questions throughout this evening's presentation, please utilize the Q&A box and we will address as many questions as possible at the end of the webinar. As a reminder, this webinar is being recorded. I'm Mohammed Al-Masri, the chair of the WHS Education Committee, and our speaker for today's webinar is Dr. Shawn Tejiram, and our moderator is Dr. Shannon Layton. To you, Shannon.
Hi, I'm Dr. Shannon S Layton. I'm an associate professor at University of Alabama at Birmingham School of Nursing, and I'm a member of the Education Committee here at Wound Healing Society. It's my pleasure to introduce to you tonight's speaker, Dr. Shawn Tejiram.
Good evening, guys. My name is Shawn Tejiram. I'm an assistant professor of surgery at MedStar Washington Hospital Center and Georgetown University School of Medicine. I'm one of the burn surgeons there, and I am quite excited to talk to you all about the second part, I guess, in our now series of burn lectures, talking about some advanced burn diagnostics and techniques. I got my slides up. If anybody has any issues seeing them, please let me know. Otherwise, I'm going to go ahead and start advancing my slides. No disclosures financially. And the objectives of this presentation are to once again kind of touch upon and review some basic burn fundamentals, kind of similarly to our lecture series part 1 in February. And then we're going to talk about some advanced diagnostic modalities for burn injury assessment, and then also review some clinical decision support tools that we use in burn resuscitation. Just a reminder who we are. I'm one of 4 partners now. We're the Burn Center at MedStar Washington Hospital Center in Washington, D.C. We're the only adult burn treatment center in the Washington metropolitan area. So that services Washington, D.C., Maryland, Virginia, but also Eastern West Virginia and Pennsylvania as well. We're the regional referral center not just for burn injuries, but complex and desquamating skin diseases, complex wounds, traumatic wounds, surgical wounds, so on and so forth. And our spectrum of care is quite diverse. We service a burn ICU as well as a burn step-down unit. And we also provide 5-day-a-week outpatient burn clinic coverage, as well as chronic wounds and a surgical wound clinic as well at our center. This is what that looks like. It's intense ICU critical care management of burn injured patients, multidisciplinary care from a multidisciplinary set of providers, as well as a fully functional and fully featured research group that it provides both clinical, translational, as well as basic science research in the care of burn injury. I think it's always important to put into context how severe burn injuries can be, and it is something that affects not just us domestically, but globally as well, with as many as 11 million injuries per year worldwide. The mortality, of course, is highest in low and middle income countries, and advances in care can reduce the length of stay, mortality, and improve functional outcomes. Why has that happened? Well, this is through decades of advancements and improvements in burn care, and that goes all the way back to the 1940s with the introduction of antibiotics and broad-spectrum antibiotics, eventually to the development of advanced and modern fluid management practices, all the way to recognizing better outcomes with early excision and grafting, and then eventually the use of skin substitutes and various grafting strategies. As we get into the 2000s, 2010s, and now 2020s, we're looking at advanced diagnostic modalities, both to improve the care of our patients, but hopefully to reduce the morbidity and mortality that are associated with this acutely injured group. To get to our advanced diagnostic modalities, particularly the imaging modalities, I think it's important to review why assessing burn size is so important. The size of a burn, as well as the depth of a burn, will dictate the amount of inflammation somebody sustains following their injury, and as a result, that dictates fluid resuscitation, how extensive it needs to be, how much you give, and how your management is going to proceed. And depending on the size of burn injury, that will suggest mortality in concert with other variables. Larger TBSA burn sizes usually portend a higher mortality and/or morbidity associated with these injuries. Again, as a review, just so you can understand burn depth and kind of the context that we're talking about these advanced diagnostic modalities. A first degree burn is the most superficial layer of skin injury that is at the level of the epithelium. And if you look at kind of the right figure schematic here, you'll kind of appreciate just how superficial these injuries are. It's usually just red, not open wounds, but it can have some very superficial desquamation. Hurts a lot for the first 24 to 48 hours, but it will get improvements over time just with simple emollients, supportive care, and time in waiting. Second degree of partial thickness injuries are down to the mid portion of the skin, down into the dermis. The injury results in separation of the layers of the dermis and it may become fluid filled. That's why you get the characteristic blister appearance that follows after second degree burns. These hurt quite a bit. They're not so deep that they've affected peripheral nerves, nerve fibers, so on and so forth. That's why you get still intact sensation, blanching skin because you still have adequate blood flow to the wound bed, and these take about 2 weeks to heal. Third degree burns are down all of the layers of the skin down to the soft tissue fat. And this will result in a kind of a dry, leathery appearance. Insensate, they might feel some pressure, but they don't feel like they did before. And the problem with these is that all of your adnexal structures are injured in this process. So your hair follicles, sweat glands, and all of those things where you have regeneration of skin to help provide skin and wound healing are eliminated. You effectively have dead tissue on the body. And the only way for this to get better, unless it's a very small third degree burn, is for surgical excision of said necrotic or dead skin and tissue. And fourth degree burns are referring to burns that are even lower than that, past the subcutaneous layer down to the muscle, fascia, and bone. We usually see this in electrical injury after all those electrons are transversing and traversing the body, and they're trying to go through the point of least resistance down to the ground, and that results in electrons flowing through pretty much the entirety of the body, causing burn injury on the inside. These are the type of injuries that are usually not amenable to reconstruction and usually require amputation. And that's why it's so paramount to understand and assess these depths of injury. Some of it is obvious, of course, especially when you see something like this in image, but some of it is not so obvious. While all of those pictures I just showed will give you a direct visualization to help you assess burn injury, there are other non-direct ways that we may assess burn injury and depth assessments. That might just be simple capillary refill, the sensation somebody still has from the wound bed, as well as the presence or lack thereof of hair follicles, or if you see hair follicles, if they get removed quite easily. We may even do some basic things like pinprick or proprioception. Technically, the best way to assess it would be by a simple skin biopsy, sectioning it out and looking at it under a microscope as histology. But this is not something that can be readily done, or people have the resources to do so, and something that could potentially heal may have a biopsy scar as a result. Other modalities may include special imaging techniques, and that kind of belies this portion of the talk where we're talking about some advanced diagnostic modalities that can help assist a provider, whether they're experienced or not, in assessing the breadth, depth, and severity of burn injury. When we're talking about determining depth, even those by burn surgeons are best done under serial evaluation. I usually tell my residents and team a wound is either doing two things, it's either getting better or it's getting worse. It's never really static. But even under serial evaluation, we're only right about 3/4 of the time. And if we compare ourselves to people who don't see burns day in and day out, those individuals are usually only right about half the time. Why is it also important to correctly diagnose burn injury size and depth? Well, underestimation may lead to delayed resuscitation. It may lead to delayed surgery and as a result, delayed healing and associated complications. Overestimation may result in over-resuscitation. Remember, we give fluids for severe burn injury, and if we overestimate, we might give too much fluid to somebody, or they may result in over-excision or excision of areas that may not need to be removed during a surgical session. So that begs the question, is there a role for an objective, rapid bedside tool? Before we continue on to that, the other thing I want you to appreciate, again, is how we determine burn size. There are two well-known methods. One is the rule of nines, and one is the Palmer method. The rule of nines basically refers to referring to certain portions of the body in terms of multiples of nine. So if we have 100% of a body that we estimate as a total body surface area, you can divide parts of the body by percentages of 9. The best way to remember this is each arm in its total is equal to 9%, and the head in total is 9%, and everything else is 18%. So your anterior torso is 18%, your back is 18%, each leg individually is 18%, and when you include the genitalia as 1%, all of that adds up to 100% of the body. So if I had somebody that came in with a circumferential burn that was well circumscribed from fingertips all the way up to the shoulder, I know that it's 9% TBSA just by rule of nines. Honestly, it doesn't quite work out that way. Usually burn injuries are very patchy, discontiguous, and it's not as well demarcated as one would like when patients are presenting. But if I have an idea of what portion of, say, an arm or a leg are involved, I can at least intuit before I see a patient myself about how much percentage is involved. When we have discontiguous burns, an easier way is using the Palmer method, where we estimate a patient's palm to be 1% of their total body surface area. And just to show our work, if we have an image such as this and we look at it and we compare it to the patient's palm, we would estimate that is burn that is 1% TBSA. And it's important to know this, especially when you're using the lingo when speaking to a burn surgeon, because we understand TBSA percentages more than getting all the measurements, diameters, perimeters, so on and so forth. There's also the concept of burn wound conversion. So as I mentioned earlier, burns are either getting better or they're getting worse. And if we have a delay in whatever, fluids, topical antimicrobial care, antibiotics, so on and so forth, we put certain portions of that wound bed at risk for converting. So if you look at the leftmost figure, there's the concept of the zones of injury. So the centermost portion is the zone of coagulation. This is effectively dead tissue. You can think of this as the area of a wound that was probably the most in contact, say, with a source of heat or whatnot. And this is irrecoverable. This is dead tissue that has to be removed. Surrounding that is the zone of stasis, which is an area that we want to support and get to heal and could potentially heal, but it could also potentially turn into that zone of coagulation. And then the zone of hyperemia is that redness that you see around the wound bed, where you have increased blood flow because of the inflammatory response, all of those things that are necessary for wound healing. As you can imagine, if that zone of stasis turns into the zone of necrosis, you're going to have a bigger wound on your hands. So it's very important for us to figure out and predict what areas of a wound are at risk for potential conversion, because now we're dealing with a bigger injury, bigger mortality, bigger morbidity as a result of that. One such type device that's been introduced is something called laser Doppler imaging. This has actually been used for, I want to say, decades now at this point. And it has since turned into and developed into a point of care device. You can see the workstation here on the right that you can actually just roll up to a patient, use that articulating head to scan somebody's wound with a laser, and that spits out the images that I have here on these slides. So the top image shows you what you see in the computer software on the workstation, but the lower left kind of is zoomed in on really the areas that you're worried about. So if you look at the bottom of both of these images, it kind of has this rainbow set of images where the red means that the laser is detecting high perfusion in the wound, whereas something that is blue or green is detected as having low blood flow. And the way this works and you would interpret it is areas of high perfusion, those red areas, are more likely predicted to heal within 2 weeks. Whereas those areas that are yellow or green or blue are more predicted to not heal and very likely will need surgery. There's a number of literature on this supporting the use of LDI to help facilitate physician assessment, provider assessment, and surgical interventions. And we have done studies ourselves on LDI where we have suggested protocolization and workflows in order to help incorporate LDI imaging both into the assessment, debridement, hydrotherapy, dressings, and admission or discharge for a patient. This is FDA cleared to be used within about 48 hours to up to 5 days after injury. And there are some thoughts that it may be too soon to use it within the first 48 hours because of the hyperinflammatory response following burn injury. Another idea is using a fluorescent dye at the time of surgery. So this is kind of a point of care injection in surgery where you inject ICG and you use immunofluorescence to map tissue perfusion intraoperatively. So if you can look in that lower left corner, you can see an image kind of similar to when you do like cholangiography or intraoperative biliary assessments using ICG. You have something that allows you to see how well a wound bed is perfused at the time of surgery, and that can guide excision margins, whether you're going to pursue operating on something versus not, because you can see how well something is perfused. And depending on what you end up excising and or grafting, you can end up observing and tracking the wound bed over time to see how the wound ends up healing over time. Another modality is something called infrared thermography. And you can think of this as a non-invasive oxygen and temperature mapping of burn tissue. This is a nice photo here in the lower right corner where you can see it's a portable device hooked up to an iPad with associated software, and it basically shows you how well oxygenated a wound bed is. And if you go back and think to the LDI, it's kind of a similar concept where you're using something to image and guide how well perfused a wound bed is. The LDI was looking at perfusion, meaning if there was still good blood flow to the area, the laser can detect that through laser imaging technology. Whereas this, you know, if you have good oxygenation, you have good blood flow to the wound. It can detect at-risk skin that might be heterogeneous to observation or maybe not otherwise observable. And it's been demonstrated to have early detection of tissue at risk of necrosis, essentially turning into that zone of necrosis that I was intimating earlier. Spectral MD is another interesting product. It just got FDA approved, and it uses a handheld device that you end up scanning a wound bed, both to help you determine depth assessment as well as TBSA burn size. And the whole thought behind this product was, well, if you're in an area, austere environment or whatnot, where you don't have a lot of experienced burn providers, well, how can you accurately assess size and depth? And if we can provide a device that lets you do that at the point of care, that can help portend better outcomes, assessment, interventions, and so on and so forth. The other part of this is that it's an AI-powered device. We were one of the institutions that were part of the study, and we would, as providers, literally paint out with our fingers the images that were scanned into this machine. And then there were truthing sessions where providers would go and confirm and deny assessments so that you could train the machine for better and improved accuracy. Um, Ultrasounds have been used to guide burn depth assessment. This is a paper that's a part of Dr. Al Masri's group, actually, and I'll certainly defer to him to jump in if he has anything significant he'd like to say about his work, but I'll try to do my best to summarize it. In this paper, he basically came up with this algorithm called CODER. It's a knowledge-driven reasoning framework. And the whole idea was you give ultrasound guided imaging information into this. And it was kind of a proof of concept in order to start determining burn depth based on those ultrasound images. And this kind of idea and concept was taken further in some further work by Dr. El Masri, where not only did he supply a digital photograph, but also Doppler imaging into a multimodal artificial intelligence agent. And with the input of a burn surgeon, was able to spit out, well, how deep is this burn injury? And would this injury need surgery by decree of it being a third degree or deeper injury? And he had some pretty compelling area under the curve results that showed a pretty high diagnostic accuracy in terms of identifying burn depth and need of surgery using ultrasound guided imaging. Our group has also looked at artificial and machine learning in burn diagnostics. And as I intimated before, it's a complex visual task. Even burn providers have limited accuracy at times in diagnosing burn wounds. And misclassifying it again can lead to issues such as delayed grafting or avoidable excisions. So when you get an image like this, you might think, well, a lot of it is red, so it's probably second degree, but then you look at it a little bit more, and some areas look a little bit more pale, and then you're not quite sure, is it full thickness, is it deep dermal, is it mixed? And that's where these burn diagnostic and advanced modalities can come in and assist. If you look at the history of artificial intelligence in both diagnosis, in-depth diagnostics, as well as burn use in general, remember I intimated that LDI is a more older technology, but it has been proven in terms of measuring perfusion units to gauge burn depth and healing potential. Neural networks are a concept where kind of similar to the way trying to map how humans think, you create these neurons, basically these data points, and you use machine learning to kind of train and also improve over time um, diagnosis, assessment, and predictiveness based on images that are supplied to it. This has since evolved into the commercial large language models that we know well today, like your Chat GPTs, Geminis, and whatnot. And the big difference here is that these are easily accessible, more cost effective, and have a lot of compute power behind them. And they now have computer vision capabilities, which led us to the interest, well, we don't have all these fancy tools and devices. Can we just simply supply de-identified information to an LLM and see if we can get some compelling assessments on burn depth, size, and TBSA? We used a 92 image data set, and we basically did similar to what Dr. El-Masri did, where we had this LLM assess these images, determine depth, and determine if something needed surgery or not. And from that, this is our results. But what I want to point you to here is what we were trying to figure out is not only could it identify or not, was there a difference between using the GUI interface, basically typing in chatgpt.com and supplying the images, or using an application protocol interface, where if you think back to your old Microsoft Windows 95 days when you had to do something kind of beneath the start menu, you had to go into command prompt and type your commands in by line. That's what an application programming interface is. And we prompted ChatGPT using that style to see if there was any difference. And what we found was that burn clinicians, as compared to the LLM, was still more accurate, but there wasn't any difference between the GUI or API interface between them. Um, and there were differences between the clinicians and the API and GUI interface. So the API was more accurate compared to clinicians when we did a kind of a command prompt interface. But when we used the actual GUI itself, it trended close, but it was not significant actually. So I think this brings up an important point that when you're using depth diagnostic tools like this, especially for burn depth assessment and using LLMs, you want to consider your prompting strategy as well. And that gets into a greater discussion about LLM use, which is beyond the scope of this talk, but I think some important food for thought as that's being considered. Now, Dr. Al-Masri kind of continued with this, and he and his group used their experience and training to come up with an artificial intelligence that could be readily trained based on previous imaging and the knowledge of what is and what isn't superficial and deep burns. And they basically demonstrated kind of a proof of concept where if they're supplied images, the artificial intelligence can scan through an image, identify what the injury is, and identify how deep the injury is, providing a potential avenue for both burn providers and non-burn providers using various tools for depth diagnostic assessment and assistance. Now, if we go and move on beyond burn size and depth assessments and tools that augment and assist providers with that, there are other ways that some of these type of tools can assist burn providers. Now, if we go back to that first slide, I said burn size is important because it dictates both mortality and fluid resuscitation. If you can understand conceptually that any burn causes an inflammatory response, and we have the capacity to mitigate that inflammatory response, meaning it happens, it's necessary for wound healing, but our body is able to kind of control it to the point where if there's any physiologic derangements, our heart rate goes up, our respiratory rate goes up. We have some mechanism of compensating for it if that were to happen. At a certain percentage, about 15 to 20% and above, the severity of the inflammation overwhelms the body's ability to compensate for that. And the reason for that is multifold, but if I can just kind of simplify that, the severity of the inflammation leads to leaky blood vessels, where you're not only losing fluids in the intravascular space, but you're losing protein as well. So you lose that hydrostatic force and you lose that oncotic gradient. That leads to less total body fluid volume circulating through the organs. And then that inflammatory response kind of impedes the heart from working as well. So the heart doesn't pump as well because of the severity of the inflammation, and Because the way the heart works, it pumps harder the more it stretches. If there's less fluid going into the pump, it's not stretching and contracting as much. It's all a vicious cycle that leads to inadequate blood flow and perfusion, therefore inadequate oxygen delivery to the rest of the body, and we term that burn shock. This is a schematic kind of demonstrating that. You can see this as a blood vessel here, and as the inflammatory response happens, there's a lot of gap junctions that lead into the interstitial space, and you end up with fluid and proteins escaping into there and not going back into the blood vessels and into the circulatory system. The American Burn Association recommends high volume fluid resuscitation. I think what has been commonly known has been the Parkland formula, which is 4 milliliters of fluid times the patient's weight times patient's percent TBSA. But a lot of literature has shown that people tend to over resuscitate when they're using Parkland formula, and you lead to all sorts of complications like compartment syndromes and whatnot. And as a result, a lot of research has gone into seeing if we can give reduced volumes, and that's where the modified Brook, or now known as the American Burn Association consensus formula, comes in, which is basically half of that, where you can safely give half the amount of volume without any significantly morbid or worsening mortality outcomes. Now, the thing to remember about that formula is that gives you the total amount of volume you'd expect in a perfect situation to give in 24 hours. So you don't actually start with the amount of fluid that you get from that calculation. You divide it down to an hourly rate. You start at that rate, and then you titrate your fluids up and down every hour depending on your endpoints of resuscitation. Our classic endpoints of resuscitation are urine output, but we might also look at base deficit from arterial blood gases, or even lactates are used at some institutions to help guide whether somebody is adequately resuscitating or not during a burn resuscitation. That's begged the question, is there a better way to automate or guide providers during these resuscitations? And that's led to the development of clinical decision support tools that can help graphic or visualize fluid volumes as they're given, totality and whatnot, and can help individualize hourly fluid rates for patients based on a number of diagnostic criteria and factors. One thing that's been developed has been something called Burn Navigator. You can think of this as a clinical decision support tool that basically tells a provider, usually a team of physicians, nurses, APPs, residents, so on and so forth, how they should titrate their fluids over time as somebody is resuscitating. The image on the left looks like the software as it was initially developed, and this was originally developed by the military. It was found that when you're getting soldiers out of austere environments with severe burn injuries, you may not necessarily have a physician or a nurse with them as they're transporting to a military hospital. And this was developed to help guide whoever was with a patient on how fluid should be titrated until they're able to get to a center where they can provide experienced burn care. So if you look on the right here, this is a more contemporary example of what this support tool looks like now. And it's actually a web app. I can look this up on my phone or on a web browser, any type of computer or PC, and so on and so forth, and be able to track and see how fluid resuscitation is going. The green curve here tells you how the fluid is going per hour, and it can give you the total amount. You think of this as cumulative fluid volume over time. The green line represents the consensus formula that I told you about before. The yellow line represents the Parkland formula that I told you before. And this is the IV index, meaning there is literature supporting that this is the amount of fluid where you would expect to significantly increase your risks of complications, whether that's abdominal compartment syndrome, extremity compartment syndrome, orbital compartment syndrome, even pulmonary edema, ARDS, pneumonia, so on and so forth. It portends worse outcomes if you're going over this amount of fluid in a patient. A lot of this work has come from Salinas and his group, and they've published a number of studies looking at the effectiveness of Burn Navigator in resuscitation. This is one such paper, I believe, back from 2013, where they assessed resuscitation volumes and outcomes between patients who used Burn Navigator and those that didn't. And they found that there was a significantly higher incidence of burn shock in patients that did not use Burn Navigator, and that overall they had a similar 28-day mortality, meaning Burn Navigator was not inferior to not using Burn Navigator and using institutional protocols for titration of fluids during a burn resuscitation. So they found that it was comparable to non-CDS formula use. It decreased the incidence of burn shock, as I mentioned. And early initiation also resulted in lower overall fluid volumes, and they were infusing at a rate less than the IV index overall, usually in these patients. Since the introduction of Burn Navigator, there have been other software platforms that have provided fluid resuscitation monitoring. One such program here is Pixamed, which is a commercial product that interfaces and integrates with various electronic medical record systems. This is not as commonly in use in my experience, but it is another product that's being offered. And that's begged the question for our group, well, these products are great, but if somebody is in an austere environment or a third world country and can't afford these products, what are their other options? And kind of similar to the burn depth and size assessment through an LLM like ChatGPT, we asked the question, could you use an LLM to assist in burn resuscitation? So for this work that we're planning to present at next year's American Burn Association, we used ChatGPT and came up with a prompting strategy where every hour we're providing burn diagnostics like TBSA, weight, presence of shock or not, vasopressor use, hyperglycemia, so on and so forth, and comparing it to what Burn Navigator would have predicted for that given hour of fluid titration. And as you can see from this blind Altman plot of agreement, the majority of fluid hour recommendations by an LLM was pretty similar to what was recommended by Burn Navigator. In fact, about 95% of the recommendations were very close from a statistical level. So we were able to demonstrate for a good majority of these prompting strategies, we can get similar results with an LLM versus something like Burn Navigator. This has also begged the question, well, are there new biomarkers that we can identify beyond just lactate, base deficit, and urine output that can help us predict outcomes, maybe in time of care interventions, or even within that initial 24 hours? And that's led to the interest and application of omics in burns. Now, if you're not familiar with omics, omics as a concept is an individualized care per patient, whereas we have a lot of guidelines, clinical practice guidelines. It's kind of a one shoe fits all type of model. This is kind of a reverse model where we try to identify things specific to a patient and patient factors that we should consider while managing somebody with a disease process or injury. So for example, in cardiology, that would be the probability of antibody-mediated rejection or allograft transplant loss specific to patient. And this has been used quite a bit in the world of oncology, where you utilize this technology to target therapies for various cancer and chemotherapeutics. Well, our group did an early look at immune pathways and shutdowns from a transcriptomic point of view, essentially your RNA pathways for severe burn injury. And what we found was for patients with severe burn injuries, aka TBSA burn sizes of 20% or more, there were modulation of both immunologic as well as inflammatory pathways when it came to transcriptomic analysis. And although, I have a bunch of heat maps here on this PowerPoint slide, effectively what we're finding is that there are changes based on the severity of injury. And if we can fine tune and figure out the various pathways for each of these transcriptomes, we might be able to identify specific things that we can target both in terms of acute injury for management, as well as long-term in terms of outcomes and maybe, say, burn wound sepsis management. This is a group out of China that took that idea and looked at some specific warning markers in a multi-omics analysis. And they actually found that a specific protein, S100, was predictive of burn sepsis in their patient population. So it can be done, it can be identified. This is all still very early work, but if we can identify specific shutdown pathways or inflammatory pathways or immune pathways that could be modulated both in the acute period after acute injury, but even long-term throughout their hospitalization, especially for our bigger burn size patients, it could represent areas of focus, modulation, treatment, individualized management strategies, and maybe even the eventual development of point of care strategies for these new biomarkers. There are challenges in the application of omics. You require a lot of data in order to eliminate these pathophysiologic pathways. So this is a very kind of new paradigm, much like LLMs a few years ago, which I would argue is still very new and novel in the world of burns and in medicine in general. But omics data, you need a literal ton of it in order to get some profound information out of it. A lot of this analysis is dependent on artificial techniques, your machine learning and deep learning strategies. And the accessibility of these kind of things are important. And, we can certainly talk about it and consider it for the other diagnostic modalities I presented previously, but you really need centers for mass processing of these data. You need understanding of these data. You need to be able to integrate it with your EMRs. You need to be able to translate the results and see if you have meaningful data that can be interpreted, managed, and whatnot. And with all of this, much like AI and LLM use, you have to understand that these individual genetic data is dependent on informed consent, confidentiality, HIPAA guidelines, and comfort with interfacing them with these technologies. And it's important to remember that a lot of this data also comes from animal studies as proof of concepts. You really need large-scale randomized controlled human studies in order to demonstrate clinical efficacy and safety. Like I said, biomarker use is a pathway. It is a process, and it requires kind of long-term stratification, getting approvals, cost-effectiveness studies, and whatnot. But it represents a fairly promising avenue for potential new and novel ideas, both in burn practice, burn assessment, burn management, and so on and so forth. So I'm going to cut it a little bit short. That was advanced diagnostic modalities and advanced diagnostics that can assist with initial management and resuscitation strategies. That's not even touching the advanced surgical techniques and all the cool toys and grafting strategies that we have in the world of burns. And after talking with the team at the Wound Healing Society, I think we're going to park that and save that for a part 3 potentially in the future. So please stay tuned for that for future discussions. Going to acknowledge and thank my group for their assistance with these slides, training, teaching, so on and so forth. But I also like to give a special shout out and thanks to the Wound Healing Society. I think these lectures are great and excellent. I got to thank the education committee for the invite for presenting this work, our work that we've done in these kind of advanced diagnostic modalities, as well as the opportunity to present to you all. It's very much a pleasure, and I take great pride in presenting the stuff that happens in the burn world, but also with our group as well. With that, I'd like to thank everybody for the opportunity to present this work, and I'll be happy to take any questions at this time.
Thank you, Dr. Tejiram, for that excellent presentation. And I will go to the chat now and start to take questions from the audience. Our first question that we have concerns what are the limitations of the various diagnostic tools? And they asked if you would address imaging and resuscitation tools.
Sure. Yeah. So if we go back to the imaging things that I presented, and that is by no means the only imaging modalities, but that's probably the most well-known and well-developed at this point. Things like LDI are probably, there's a cost factor associated with this, both from the device standpoint and also introducing these things. So if you talk about the LDI, you got to pay for the workstation and whatnot. So there's a financial component of it. Then there's a workflow cost. So when we were introducing LDI, for example, to our group, what do you do about the 3 a.m. presentation and the burn attendings are not necessarily in-house to run an LDI machine? So now you have to train the trauma nurses who are also managing all the gunshot wounds and car accidents that are coming in and figure out a methodology that they can incorporate this because the hydrotherapy and dressing management can be quite painful for patients as well. So there is a labor cost associated with it. And then there's a knowledge cost as well. You have to have providers that actually know the diagnostic tools, how to implement them, how to use them, and have experience doing so with other products necessarily. Things like the ICG, you need to have tools in the operating room that allow you to do point of care immunofluorescence, for example. And things like your ultrasound studies, you need to have those kind of devices that allow that resolution in order to provide it. Now, in terms of the burn resuscitation tools that we have, again, there's a financial cost for it. So there are products that you need to be able to pay for or subscribe to in order to have them integrate with your systems and also have permission to use. But on top of that, again, there's a workflow strategy. We have a strategy where we train and teach our nurses to incorporate Burn Navigator into their nursing assessments in order to help automate some of the titrations that are happening. And then there's also, again, the knowledge costs where if I have a differing opinion from, say, Burn Navigator and which way we should titrate, there needs to be methodologies, methods, carve-outs for me to have precedence over such an event happening.
Thank you. Our next question is, what of these technologies are you using in your personal practice at your center?
Of course. We have an LDI machine that we use, especially if there is any kind of question about the depth of diagnostics and it comes down to the question, should we keep them, have them go home? We use Burn Navigator pretty much for all of our burn resuscitations now at this point. And we've evaluated other programs like, for example, the Pixamed product and whatnot. We have done research studies looking at ultrasound use in various burn diagnostics, not necessarily burn depth and size assessments. And we've been a part of other imaging modalities, like I mentioned before, spectral MD, but we have not introduced that as part of our regular practice as of yet.
Okay, I'm going to go to the open chat really quick and see if we have any additional questions.
So, thank
Uh,
you, Dr. Tejiram, for this wonderful, presentation. And Dr. Shannon Layton, if you allow me to ask question or jump in the discussion. I have a question regarding the data set or the repositories for the training the large language models and integration of the AI over there. What do you think about the availability of large data set like in the centers of like burn centers, American Burn Association, because I feel that this would be the future for to get precise and accurate algorithm output. You have to train the model like so many thousand images,
Oh
which we
yeah,
currently, I believe it is not there. Your insights would be greatly appreciated, Dr. Tejera.
of course. No, I agree with you. I would say that's a big problem with getting a lot of these projects off the ground. And the reasons for that are multifold. The first issue is effectively HIPAA, like getting permission from people for doing it. I don't think that imaging, and this is up for debate, I'm sure, imaging in electronic medical records or whatever system somebody uses for their institution necessarily falls under the same rules as other data, like simple lab work or documentation or notes and whatnot. Mainly because there are other identifying factors that happen with the patient. And as much as you try to de-identify things, if there's something like, say, a tattoo on it that's right next to a burn, that is still something that's identifying. Number two, the scope of the image can be problematic too. So some of these studies, I noticed that you literally cut out the burn and feed it to the image generator. But the problem with that is you don't have context. So you don't have the entire appendage or limb. So therefore, you don't really know what the total percentage is unless it's inputted. That kind of limits kind of some of the studies and diagnostic modalities you can do. Number three is the quality of the image. Well, who's taking the pictures? Is it your research personnel? Is it your nursing staff? Is it your students, residents? Are you taking the pictures themselves? These are not photographers. So you're not necessarily going to get the best image or the best aerial view of a wound that you can do a lot of great training on. Number four, it kind of depends on what you have at your institution. Some of these images are very easy to kind of collate and bring together, and some of them are very difficult or time consuming to do so. Um, which has led to, well, can we find de-identified available diagnostic image sets that we can train these models on? And honestly, it's been difficult for even me. Like my group has tried to find these de-identified kind of generic safe images that you can use. And I think we found one that was like 1,000 images. And then as we went through it, we were like, well, why are there rashes in this image set? Or is this actually a burn and whatnot? So there is a time and validity cost to finding various quote de-identified generic burn databases as well. It would be great if we can come together and have some type of de-identified generic database that anybody can start large language vision-based questions and hypothesis generations against. But I think that's going to take something probably on the level of like say an American Burn Association providing something like that, similar to their BQuip data set, which is kind of a general generic set of data among various burn registries at various institutions that are shared so that you can kind of do kind of, large 50,000 foot view studies on burn specific stuff. So great question. Still an area of big debate, I think, and some potential solutions, but it's going to require a lot of discussions and collaboration.
Yeah, that's what's great, and a lot of more than what I expected regarding the obstacles regarding
Mm.
the availability of this data set.
Oh yeah, I've
And
had a lot of time to think about this.
yeah, uh, I just wanted to highlight if there is like if we have any questions from the audience, or should I go ahead, Dr. Layton, to
I have one question about the large language model for use in third world country. When looking at the graphical representation, are you noticing any trends in the outliers, and how are you improving prompts? How do you go about that process?
Sure. So when we start seeing, so if I go back to that image that I showed you guys on resuscitation volume recommendations and how they compare to what Burn Navigator is, what we found was moderate fluid amounts. So like your 500 milliliters to 1 liter per hour were more likely to be discordant with Burn Navigator. It all has to do, we're finding right now, with our prompting strategies. And again, this is kind of beyond the scope of the talk, but if you want to talk about prompting strategy specifically, I don't think that there's a universal prompting strategy or generic like template or whatnot to get what you want. Like you really have to kind of self-develop that in order to have reliable, repeated responses returned back to you. The other wrinkle to all this is, say you use ChatGPT today, 6 months from now, ChatGPT is going to be very different. I think they just announced 5.1 today or yesterday. When we did that study, I think we were using 4.0. And the other wrinkle to all this is you cannot necessarily go back to a very specific version of ChatGPT on said day. So as much as you try to optimize your prompting strategy, you may not even get the same result depending on a different version of ChatGPT on a given day, on a given workstation, so on and so forth. So I think that's something that we're still trying to tease out. If we can simplify and get as generic of a prompting strategy where you don't have to type in much and you get a good enough result, that might be good enough for somebody who just needs something to get by.
Yeah. And I'm going to look one more time to see if we have any remaining audience questions.
I think while we are waiting, I just wanted to highlight, like, the studies which Dr. Tejiram presented regarding the ultrasound like use. Actually, like, our group used this methodology, a little bit different approach because we have two modalities in the ultrasound, the B mode, which is regular ultrasound, which we see the black and white images. And then there is another modality which called elastography mode, which you assess the tissues according to the elasticity of the tissues, the water content, the proteins, and everything. So if the tissues, like I will give it like in a very simple way. So if the tissues are stiff or fibrotic or necrotic, then you are having a lot of hard when you are pressing the probe over there. It is inelastic or less elastic. When you have inflammation, the tissues are like, soft, subtle, then you have like more of elasticity over there. So with the Gauge strain that already in the ultrasound probe with the indicator on the screen, you can limit your pushing on the tissues and you are getting the response back within the green bars over there. So the image which will come on the screen would be actually multicolored image, like similar to the image which you presented, Dr. Tejiram, regarding the rainbow from the LED eye over there. It
Yeah.
would be
Yeah.
similar to that. And according to the color pattern in those layers and the elasticity in the tissues because of the protein denaturation by the burn injury itself, it will reflect in the color pattern. And when you are taking this and training the model or the AI model, oh, this is actually first degree burn because of this color pattern. And this is second degree because of that. And third degree because of this extensive blue color over there in these layers of the skin.
Right.
Of course, when you are training the model, you are giving the gold standard, which is the biopsy, to make sure that this is histologically validated. And you train the model, and that's why we came out when you saw the area under the curve and all of those, the precision, because we validated the results and the feed for the AI itself by the histological validation before, like, interpreting those.
Right.
Of course, it needs a lot of like training and data set as we discussed. That's why I was asking you about your experience for availability of the data set. And that would be great if there is like multi-center, like, data
I think
repository
that'll
or
be key. If we can't get something at like an organization level, then we should try to do some type of multi-center database.
yeah.
Okay. And I am checking to see if we have any other audience questions. And at the moment, we do not. So we are free to ask you a question ourselves. And so with that, when you think about the future of AI and getting participants to become willing, what do you think we can do as providers to encourage our participants to trust AI, trust their privacy is not being violated, so we can better gather a broad base of participants in the various studies?
I think it depends on the strategy of the study. So if you're just point blank using Chat GPT with patient information, I don't know if that's the most appropriate, and there's no way to guarantee that any of it stays safe or private. But if you develop like an in-house artificial intelligence where everything stays secure, is secured on HIPAA compliant computers or not accessible otherwise or searchable or anything like that, I think that's a more appropriate and palatable ask for your patients whenever you're including them in research. Well, it was a pleasure presenting to you guys, and I think we've had some great questions so far, and I think I'm gonna look forward to part three of our burn discussions.
Yes, for sure. That's our pleasure that we have you today for the second part, and we are looking forward to your next part for the advanced techniques in the therapeutics of the burn in general. And we will plan and announce about this like very soon. And I would like to thank also Dr. Shannon Layton for her moderation to this webinar tonight. And I would like to thank all the attendees and for today's session. And today's webinar brought to you by the WHS Education Committee and Wound Healing U. As a reminder, the recording will be available in your member-only account in the Wound Healing Society and Wound Healing U, and on the WHS YouTube channel in the next few weeks. And please don't forget to register and stay tuned for our next webinar on December 10th at 6 p.m. Eastern for chronic pelvic wounds and osteomyelitis with Christina Miguel and Lisa Gold. Thank you again, Dr. Tejiram, Dr. Layton, for your attending today's webinar and speaking and moderating the session, and looking forward for our next webinar. Thank you.
Thank you.
Thanks, guys. Appreciate it.
Thank you.
Thank you.